experts in pediatric deformity, both at the Shriners Hospital in Philadelphia as well as Baylor, from what I understand. And back in Philadelphia with the Shrine and also with the University of Pennsylvania now. So thank you so much for taking the time with us and, sharing your topic today on something that we all are very interested in, but maybe a little bit afraid of: pediatric deformity and intradural kind of abnormalities. So really great honor to have you with us, and thank you so much for doing this for us.
Thank you. Thank you for the wonderful introduction, Dr. Abdul-Jabbar, and thank you to everybody in the Seattle Science Foundation for letting me speak today. I'll share my slide and we kind of go through this. Does that seem to be sharing okay? Hopefully. So I have the maybe partially unique practice of being able to do pediatric deformity and practice a little bit of pediatric neurosurgery as well. So I'll try to go over some of the intersect of the two and how they overlap a little bit and dive into more of the deformity side. But please feel free to interrupt any questions or ask at the end if you want to as well. And so overall, I'll kind of gloss over a little bit of the types of pediatric scoliosis we encounter, then talk about how often we see intraspinal anomalies, things like syrinxes, Chiari malformations, tethered cord, and then some of the other unusual spinal dysraphisms like split cord malformations and whatnot. And then kind of talk about that relationship between the two, when do we have to intervene, when should we have to treat it, and then what are the different treatment options and where does it overlap a little bit more, and kind of what surgeries help. So overall, scoliosis is an overview, is about a 10-degree curvature. The SRS, the Scoliosis Research Society, defines it as 10 degrees of coronal curvature, because that's what we had initially in the PA X-rays. But we really understand that different etiologies are a little bit different. With idiopathic scoliosis, it's more of a lordotic typically process, whereas other types like neuromuscular may be more kyphotic. The three large overall diagnoses are idiopathic, which is the most common type we see. These are typically the healthy, often teenage, predominantly girls. And then you have congenital, where the bones are abnormal, neuromuscular, and syndromic. But the overarching diagnosis is pretty much any child diagnosed less than 10 years of age has similar issues with growth, meaning a big driver of progression of that scoliosis, the growth remaining, as well as that compounding or impairing lung development. So really we want to optimize the lung development and control the curve. So we label them as early onset scoliosis. So it's like a larger diagnostic umbrella that overlaps all of these. So whether it's more of an idiopathic curve in a healthy kid, congenital, where the bones developmentally, embryologically are formed differently with other fused segments, or things like neuromuscular that could be CP, or syndromic like Rett syndrome, a typical diagnosis. Again, the overarching label is if they're less than 10 years at diagnosis, we call it early onset scoliosis. But so how often in these different diagnoses do we find something abnormal? So the most common, again, type of scoliosis we encounter is typically idiopathic, so adolescent idiopathic scoliosis, meaning kids that are over 10 years of age when they're diagnosed. And there's several studies. It's a little controversial in terms of should we get a routine MRI in these patients. At our institution, preoperatively, we often do. So as a standard, we do. But there's a resource management issues. Are you doing it unnecessarily? In some places, they don't because of some of this data. So there's several papers, some up to 2,000. Mo Diab's paper in 2011 had over 2,000 patients. And there's a fairly consistent number. Somewhere around 8 to 9% of the time, those MRIs will find something abnormal, at least radiographically. It doesn't mean that every time it requires treatment, but just that you'll find a syrinx most commonly, less commonly a Chiari, and then at least in North American literature, tethered cord tends to be a few percent of the time. So a little less, the least common of the three. More importantly, how often does it impact surgery? So how often when you find something, do you have to treat it? And that's a little bit different. Several papers kind of listed here have talked about it. And really the number varies from 1 to 5% of the time. And there's a lot of heterogeneity. So you can imagine the diagnosis alone between surgeons, you can see 10 different surgeons and probably get 10 different opinions at the same time. So not every Chiari needs an intervention, not every radiographic tethered cord needs an intervention, certainly not every syrinx needs an intervention. So in the literature, it's somewhere around that 1 to 3 to 5%. And some papers suggest it's actually zero. The Doe's paper, Winter, and Shen each had papers with smaller groups of patients. up to about 320 patients. But really, in those patients, none of them required treatment. So they were asymptomatic largely, or it's thought to be asymptomatic. A lot of these were seen in orthopedic clinics, so they probably referred to a neurosurgeon, and that neurosurgeon felt that they did not require treatment. So part of the ambiguity I'll get into a little later is what counts as a sign or symptom. Is the scoliosis itself a sign of Chiari? Is that a symptom of it, or is it not, or is it just unrelated? And we'll touch on a little bit of the intervention. The variability comes into, as you can imagine, different surgeons may have different indications. So there's a lot of variability with when you might operate. So how often do you find something congenital scoliosis? So we saw maybe 8 or 9% of the time you might find something in idiopathic scoliosis. In congenital, it's much higher. So routinely in these patients, when we see them, we'll get a workup and get renal ultrasound to look at basically the mesodermal structures, their development that are abnormal, along with the bony stuff. So mesodermal stuff, renal ultrasound, a cardiac workup, and an intraspinal MRI. So in the literature, it's mixed, but somewhere around 18 to almost 40% of the time, you'll find an intraspinal abnormality, like we talked about earlier. And so these, again, whether they require interventions vary, but routinely we'll get MRI. Overall, that incidence is highest with congenital scoliosis, as we saw, and then it's also higher the younger the children, whether it's related to this kind of same disease pathology, causing the curve to kind of be more apparent at a younger age and hence diagnosed earlier. It's not clear, but in infantile idiopathic scoliosis, somewhere around in the low 20s, you may find a abnormality on MRI. Juvenile idiopathic is closer to low teens, and adolescent, we saw about 8 or 9% of the time you'll find something. And so to dive into the specifics a little bit, so Chiari malformations, one of the things we often see, and one of the things often or colleagues in pediatric deformity kind of worry about. Obviously, a little bit of background. Hans Chiari described in the 1890s with autopsy specimens, but largely it's thought to be a CSF flow abnormality now. And classically, we still use 5 degrees of tonsillar descent, as a diagnostic criteria. But there's variability even with that. Obviously, you can present with headaches, classically tussive Valsalva-induced headaches. You can have a syrinx and spinal cord symptoms or lower brainstem symptoms. But it can present quite varied as well. And there's some diagnostic ambiguity with that. Some people have described a Chiari 0, which is like a web blocking the CSF flow, or Chiari 0.5 or 1.5. So it can be very confusing when you're trying to piece it together. And then also in terms of the indications for surgery, who might actually intervene, who might benefit from things, and how objective are those symptoms you're having. So you can see on the image, in the right, you can have a polyport syrinx that goes up, and that might be a reason for intervention, or it could be varied. And so it's not always a clear diagnosis. Just because the patient comes in complaining of headaches doesn't mean it's a Chiari, as this cartoon kind of illustrates that point. And that's a difficulty, I think, the students we deal with. There was a paper, I know in 2000, that was published by Hwang. It actually polled about 80 pediatric neurosurgeons, and about 8% of them said they would not operate on a Chiari, just radiographically, unless there were clinical symptoms. But then 60% also argued if there's progression radiographically, so syrinx or worsening of the tonsil, they would intervene. So there's a bit of a gray area in terms of how much progression do you need? Is the scoliosis considered a progression? It's not something historically was included. And so there's some, again, a gray zone in the middle of that. Overall, in terms of deformity, Chiari-related scoliosis symptoms in general be pretty good from the decompression. So somewhere around 70 to 90% have some post-op improvement. So whether classically tussive headaches, tend to be the best, but they decline a little bit over time. The Hopkins group with Margaret show that over time some of these headaches occur, they contain more symptoms. And we know the syrinxes often improve as well. So somewhere around 70 to 90% of them will improve. They don't always resolve, but often we'll see them shrink a little bit with adequate decompression. There's a lot of, again, variability how you decompress, whether you just do a bony decompression, whether you open the dura, do a duroplasty. So again, it's very heterogeneous how people approach this. But overall, somewhere around 79% of the syrinxes will improve after. It doesn't, again, resolve. But about 6 or 7 months, often it's better. And so with Chiari-related scoliosis, what do you worry about? There's an image of a 14-year-old girl with a large curve on the right. And typically, we look at things like left-sided curves, so things that are atypical for idiopathic scoliosis. So if they're left-sided, they progress very rapidly aside from growth, beyond growth. In the literature, people talk a lot about asymmetric abdominal reflexes, which, to be honest, I don't do as much now, but they reported that with probably the syrinx findings, and kyphosis. So AIS typically is more of a lordotic process. So if they're hyperkyphotic, often we'll look for abnormalities such as a Chiari or tethered cord. And in the literature, the Chiari literature at least, it's somewhere around 13 to 40% of patients will have scoliosis. So this is a little bias, a little selection bias, because the patients coming in all have Chiaris, but that number is higher. So we see it, scoliosis associated more common than the general population for sure, which is about 2 or 3% of the population. And then the risk factors for progression tend to be predominantly curve size. So if the curves are over 30 degrees, in some articles say 40 or 50, even if you treat the Chiari, the curves tend to progress. So if you do it later, so kids are older, some articles say 8, some say 10, but consistently those two are reproduced in literature. Some will say this, if the syrinx isn't better, or maybe you didn't adequately decompress it, so it didn't get better. And some curve patterns have been associated with it as well. But really, the larger the curve and the older the patients, if you intervene and treat the Chiari, the curve tends to not be as likely to improve or stabilize. This is an example of a 6-year-old child we had with progressive curve. We're bracing and kind of kept on getting bigger. And then she was largely asymptomatic, unless, again, you believe the syrinx is a symptom. So this is the sagittal via MRI, so your large, fairly hollow cord syrinx going all the way down with, what's this? Let me try to get a laser pointer. So you can see the tonsillar descent, the hollow cord syrinx kind of going fairly all the way down. And a cross section, a fairly sizable syrinx, the axial views as well, a little bit of flow in between. So this is, so decompressed her. I think, again, some people, I think most pediatric nurses probably would decompress a hollow cord syrinx, but again, she's largely asymptomatic. We couldn't find any clinical symptoms of this. And so we did a Chiari decompression. I classically will do an alloderm patch and do an MRI around 6-7 months after. So we see a fair amount of flow. The syrinx got smaller. There was improvement in that. And then over 7 years, she stabilized. We kept on bracing her after because the curve was already 40 degrees. It came down to about 25 degrees and has been stable there. Sometimes it gets better, sometimes it doesn't. But again, younger age and smaller curve kids tend to do better, at least have a greater chance of stabilizing. So far she's been doing well, but she still is young. So still has growth remaining. And, the story is not quite done in her case. There's a lot we still don't understand with Chiari malformations, obviously. Again, is deformity, should it be a sign? If you have an X-ray showing scoliosis, should that be along with tussive headaches, paresthesia? And should you treat that similarly or not? And that's still controversial. What do you do with retroflexed odontoids with Chiari patients? How is that impacted? So there's, again, a lot we still have to understand and don't know, but those are all areas that hopefully will continue to push forward. And then there's a little bit, the interesting point is, if you look at some of the other literature, Ray et al. Published just what they thought were idiopathic patients, about 1,000 patients that were diagnosed with idiopathic scoliosis, and 4% of them actually had radiographic evidence of a Chiari, so greater than 5 millimeters of descent on MRI. And then there's some other studies that show idiopathic scoliosis patients have lower lying tonsils, cerebellar tonsils, in the age-matched population than kids without scoliosis. And we saw earlier, patients with scoliosis tend to have a higher incidence of scoliosis. The Chiari tend to have a high incidence of scoliosis as well. So could they be related? There was the Toronto group that a zebrafish model in 2016 they published, and basically when they affected the ciliary motility genes, they actually created scoliosis in zebrafish, which does help bridge things a little bit. Could this all be on the same spectrum of one end you have very mild symptoms leading to AIS, so the expression of it's not quite as powerful, and TR1 patients maybe there's greater ciliary dysmotility, and we're seeing more syrinxes and more severe expression of it. So it's still a lot we don't know, and obviously this is being studied, but overall, scoliosis is more common in Chiari patients. So if you see these patients in clinics, certainly do an Adams forward bend, just have them put their feet together, lean forward and touch their toes. And you can see if there's rotation, if one side's a little bit higher than the other, and get x-rays if there's some asymmetry there. And if you're going to treat a Chiari, do a Chiari decompression in a patient with a goal of trying to stabilize or improve the scoliosis, I would try to do it when they're a little bit younger, before 8 or 10 years of age, and before the curve gets too large, over 30, 40 degrees. And we'll see kind of similar themes. And exactly why that happens is not clear. Presumably it's enough growth when they're young enough, so that remaining growth can help correct some of the deformity. And the magnitude, probably the biomechanical features of the curve, you get wedging of the vertebrae with increased deformity. Maybe there's a point that the body just can't overcome, even if you take out the driving factor for the scoliosis. So the second thing we see also is tethered cord syrinx. We also see a fair amount, but there's not typically much to do with the syrinx and scoliosis. Usually we just kind of are aware it's there. If there's not a separate underlying etiology or cause for it, we'll just watch it. There's some papers showing the larger the syrinx can be associated with worse neuromonitoring, so you just may not get this reproducible monitoring, but largely our surgery doesn't change. We don't change our approach to the surgery. Tethered cord is a little different. Obviously, there's also a very heterogeneous diagnosis. So spinal dysplasia in general can be anything from mylos, diagnosed at birth, to tethered cord, to fatty phylum. So they're kind of different extremes and can present with obviously different things from obvious skin stigmata, such as a dimple, a sinus tract, a hemangioma, hypertrichosis, lipoma, and appendage. And the symptoms obviously can vary from back pain, leg pain, any nerve-related issues such as sensory abnormalities, gallbladder. In kids, it's obvious they can't present, and some of the ambiguity with diagnosing or making the diagnosis tethered cord in a young infant less than 3 years of age is you can't often get reliable urodynamics. They're not potty trained, so you can't really tell if they have good control. They may not complain of sensory problems or even pain. They may just be irritable. And so until they have obvious weakness or tone abnormalities, it could be in-toeing of the feet, toe walking, things like that, you may not be able to really clinically put a diagnosis on some of these young infants. And again, it can be a range from lipomyelo to meningocele and to in utero diagnosis or even in utero closures now. So the main thing, obviously, radiographic tethered cord is not equal tethered cord syndrome. So there's a big difference. Basically a myelo patient detethered at birth will always have radiographic evidence of a tethered cord. It'll always look a little scarred, but when do we intervene becomes a separate issue. And so part of the ambiguity, again, just like Chiari, there was some gray zone of when you treat and when surgeons may, the indication surgeons may have. Tethered cord is probably even worse because then there's more anatomic variance as well as clinical nuance. So some of the issues some of the controversies surrounding tethered cord, obviously, should you treat, what is an asymptomatic child, first of all? So a 2-year-old child can't complain of pain. Could they have a tethered cord? If they're toe walking, is that just idiopathic toe walking, or could it be pathologic? And it can be difficult to ascertain. And then when do you treat? If they're truly asymptomatic, there's mixed literature. I won't dive into this too much. We're probably going to do a whole grand round just on tethered cord and the controversies around it. But I'll try to focus this talk a little bit more on the deformity aspects and scoliosis related to tethered cord. But these are certainly questions that remain to be answered. And is spinal deformity similarly a sign of tethered cord? So if you have progressive deformity but nothing else, should you go release the tethered cord to try to stabilize that curve? When to treat, again, varies in more of the neuro world, but I'll focus this a little bit more on the deformity side. So if you detether a patient, are you likely to stabilize the curve? And there's not a ton of great literature to explain this. This is one of my mentors, Andrew Gray, published a series of 45 patients. These are symptomatic tethered cord patients, so they clinically had a diagnosis of tethered cord syndrome. And then basically a third of these patients, 31%, had scoliosis with a pretty sizable curve, about 35 degrees. And they found after they detethered them, released them, about 1 in 5, so 20% of them still worsened, they still progressed. And the univariate, multivariate analysis. On the multivariate analysis, really they found that the magnitude of the curve was the only factor that predicted who would progress. And in those 20%, if the COB is greater than 35, that was their best predictive factor, which is a little similar to what we saw with the Chiari population. So Same theme, once curves in the Chiari literature, it's somewhere in 30, 40 degrees has been published. It's probably a little bit arbitrary how you measure it. If you have a big enough population to study, we probably could actually find a cutoff a little more accurately. But it's the same theme through it. And then Raj Iyer published a paper last year. It was a multi-center pediatric spine study group, multi-center study looking at 37 patients, where about a third of the patients progressed after detethering. They actually found a younger age of detethering helped, but not so much the curve magnitude. And so a slightly different population, but they had a little bit more myelorepresentation in their series. But it's a similar theme again to what we saw with the Chiari population, meaning at a younger age, maybe you can channel that growth after and get improvement or stabilization of the curve. And so there's not a ton again on tethered cord related deformity, but obviously the big things that differentiate radiographic from clinically tethered cord. So obviously if they're clinically symptomatic, we would treat. How you treat, I'll touch on a little bit. Is it partially symptomatic from the deformity? Is it just the tethered cord, the strophism? Can you not tell the difference? And then there's limited evidence, but consider the same themes of a younger, if you're going to treat them for it, maybe at a younger age, or when the curve's a little smaller. And some of this, maybe you may want to brace a child and temporize, see how they do. If they still progress, maybe then do it. And always balance, obviously, what you're doing. If it's a simple fatty phylum with a risk of 2 or 3% of anything like a CSF leak wound issue happening versus a lipomyelo that's a more complex risk that comes into the equation of should you intervene or not, which obviously why it makes it a little more ambiguous. The other thing is, in terms of tethered cord, should you treat? So classically, historically, patients that had a Chiari or tethered cord or split cord malformation or anything would have it released before deformity correction. So if you had both the deformity and spinal dysrhythmism, the old teaching was to treat the intraspinal anomaly first to decrease the risk of something happening after. And there's increasing literature saying that maybe you don't have to. So several of these papers are from China looking at outcomes without detethering or without treating the underlying pathology before treating the deformity. This is an example of a 12-year-old child. The image is on the left a little bit earlier, and then it progressed a little bit over time. There were 12 on the right. So there's this X-ray on the right. There's a little hemivertebrae here, so you can see down here. And this developing a small curve, open triradiate still, so they still have a lot of growth remaining. So the question is, do you have to, and this kid had a low conus, so there's a little fused in the bottom here, but close to L4, and a fatty phylum, so it's thickened, so both thickened phylum, but no obvious symptoms, no pain, no neurologic problems. Urodynamics were normal. And so we're planning to treat the hemivertebrae to prevent it from progressing, given the growth remaining. But do you have to go and detether this patient before? Is it safer to do so? Can you do it simultaneously? There's a couple of papers looking at concurrent treatment. In the literature, there's a couple, again, some of the largest series from China. Liu et al. Published this series a couple of years ago looking at AIS patients, or idiopathic patients, versus patients with abnormal findings on MRI. So there were still idiopathic-like curves, and they overall had about 72% correction, which is pretty good, pretty average. Good follow-up, and overall a pretty comparable complication rate, about 3% related neurologic-related issues, but not higher than the AIS population. So the argument was it's about the same. You don't have to treat the underlying problem. Part of the problem with a lot of these articles is it's a heterogeneous, it's a bit of a mixed bag of diagnoses. So the syrinx, the radiographic tethered cord, the Chiari all get lumped together. So it's not as granular in terms of what they have. And none of these patients were symptomatic. So they didn't have any symptomatic Chiari or tethered cord. In Zhao's paper, published a little before that, looked at congenital scoliosis. So it's a population that has a higher risk of intraspinal anomalies. And they had about 60 patients of it had intraspinal anomalies versus 184 that didn't. And they had a little less correction, so about 50-60% correction, but comparable between the two groups, and also had no difference in complications or outcomes. They had one patient with transient weakness that it resolved. But overall, it wasn't different between the two groups. They actually would bend and have patients bend on X-ray and not aim to get more correction than on the bends. And which can be difficult at surgery. How do you control, it's a patient sedated, asleep, how do you prevent them from leaning over more or attracting a little too much? It's a little trickier. And then Yang et al. Had a paper in 2021 looking at a larger group of 300 congenital scoliosis patients. And they actually broke it down by how many abnormalities they had. So they looked at a combination of syrinx, split cord malformations, tethered cord, low conus, Chiari, and cysts, and basically label them as having one abnormality, 1 to 2, or 3 or more. And again, it's a little bit arbitrary. The syrinx, most often syrinx we don't need to treat, we just watch. Sometimes you have idiopathic syrinxes that are not clinically consequential, but they had higher complication rates with more. So basically 6% overall if you had 1, 4% compared to 1 or 2, and then about 10% if you had 3 or more. And then about 50% correction. They included the PSOs, the pedicle subtraction osteotomies in the groups, but not the VCRs, which may be a little bit of a bias. And again, about 40% of the abnormalities were syrinxes. So it's a very heterogeneous group. So it could be a little hard to put your flag down and say something, a strong belief based on these. And then Rich Anderson published a multi-center study from the PSSG, so Pediatric Spine Study Group, also looking at should you detether patients. Most of these were myelo patients, and they looked at 3 groups. If you didn't do anything, so you didn't detether them, which was about 75%, so the majority of the patients they had, whether you detethered them staged, so within 3 months and brought them back to do the deformity correction after, which is classically how we treat these patients, or you do it at the same time, about 15%. And the numbers were fairly small in the 2 other groups, but they actually noticed a higher chance of infection, unplanned return to the OR, and then the length of stay in transfusion because the surgery is a little bit longer. But infection and unplanned return to the OR was higher if you staged it or detethered them, which is somewhat intuitive. If you're doing detethering, you're getting into the CSF space, you have a high chance of a leak, versus if you just left it alone and didn't touch them. So again, this may speak against detethering, especially the asymptomatic, really against detethering them before deformity correction. In this child, we did a hemi-excision. We took it out on the left here, and then just did a short fusion, 2 above, 1 below, locked it down and corrected them. And then hopefully taking that driving force out of the equation will prevent them from progressing above and below. I think there is a point when the curve is too big where taking a short segment out won't help. We just can't correct it enough. And it probably goes to the same point of detethering or treating Chiari before the curve gets too large. Then biomechanically, this takes on too much force, and I can be able to correct it with a smaller surgery. The flip side of this is, can you treat tethered cord with deformity correction? So, instead of treating the tethered cord and having that separate, patients who are symptomatic from tethered cord, could you actually treat them with a deformity procedure like the hemivertebrae excision? And so that's something relatively new since 1995. And we know with detethering of patients, both as the age goes up higher, the complication rate goes up, and certainly with retethering, so as you re-release them the 2nd, 3rd, sometimes even 4th time, the anatomy is more scarred, it gets worse, the complication problem goes up, and the outcomes are worse. So, but not all the anatomy is the same. So there's an example of a 5-year-old boy with clinical symptoms of tethered cord, pretty mild, and kind of a fatty phylum. This is a sagittal T2. It's a little low-lying, dorsally kind of anchored, and axial is a little bit of fat, a little spot of fat there. So in this case, a simple fatty phylum release. To the video, and it can be fairly low risk. So often now I won't even do a lamina. I'll just spread the lamina with a lamina spreader. You don't need a scope, little dural opening, raise the phylum, stimulate it, and cut it. It's a nice, very simple surgery, elegant. Overall, probably 2 or 3% risk of a complication like CSF leak or wound issue. And so if that anatomy is favorable, I think it's a great option. Just cut it. But not all tethered cords or spinal dysraphisms are the same. The anatomy can be more of a terminal lipoma or complex, and the function can be higher. So for me, the algorithm changes a little bit with the higher function the child is and the more complex the anatomy. I think usually I'll try detethering them once if they recur, just so I know the anatomy. But if it doesn't work, or if the neurosurgeon who primarily did it just said it's going to be a mess in there, I might lean towards an alternative. And so, is there a better way to do this? If we keep on detethering patients over and over the same thing, and the yield is worse, we're getting worse results, higher complications. Can we do better? So, one of the theories for tethered cord is basically kind of stretch or tension across the spinal cord. So the cat models used to do with the tension. The idea is that potentially either you have tension on the cord, so the nerve's not working well, or there's less ability for it to kind of pulsate or move, adapt to the daily grind we have, the daily movement, and that leads to pathophysiologic changes and basically neurologic clinical symptoms. So instead of releasing the bottom and shortening and taking the tension and releasing the tension, could you decrease the distance from A to B? So where it's anchored to kind of the head and the bottom, could you just change that distance and take the tension off in doing so? And so that's what Dr. Kokobun described in 1995. Basically, patients with a tethered cord, especially recurrent tethered cord, he described this idea of basically taking a part of the vertebrae out. So basically, the disc above the pedicle and then closing down. You want one level above, one below, and close down on it, decreasing that tension. And we've had multiple series since then. It's kind of still gaining in traction, but it is a very elegant way to address this. Overall, this is an example of a 9-year-old girl with recurrent tethered cord. She had AMC as well, so not totally normal, but worsening bowel bladder symptoms, getting a little bit weak and some numbness in her feet. And a fairly complex structures. All of the fat is embedded in here distally. She did have reasonably good dorsiflexion and plantar flexion, so her function was very good. But I was worried going back in here. In my hands, I thought the risk was quite high, causing a neurologic problem, or maybe just not helping her a lot. So shortening osteotomy or vertebral body shortening osteotomy for me, in this case, is an excellent choice. And so this is an example of a recurrent tether. And you can imagine how sometimes you get in there and just scar, there's arachnoid. The cord is kind of, I think if I put the laser pointer, it stops that. So the kind of cord and the roots are all stuck. Everything's adherent. And when you get to the end, it doesn't look that released. So it's all kind of stuck in here. These are videos of trying to find scar tissue from nerve, distinguish the two. And then at the tail end of it, it doesn't look that much better, maybe a little bit released. You can sew a patch in to try to help, but maybe not the most gratifying surgery in this patient. So is there an alternative? And so for shortening osteotomy, this is already done. Rostrals to the left, caudals to the right. The pedicle is here. We just took the facet out. There's a lamina. I usually just take the bottom third of the lamina above now. This is a little bit earlier. And then the full lamina, the level in question, we'll skeletonize the pedicle, take the facet out. So we'll take the superior inferior facet out, and then take out everything lateral. So in this case, I often will try to do it, I'll try to do it on T12 so that we're not changing the lateral profile, the sagittal profile for the patient. And if there's good fixation, you can go one and one above, one below, like Dr. Kokobun described. I had one patient who fractured one of the screws after a fall. So sometimes I'll go 2 above, 1 below, or 2 and 2. But then just do basically a partial VCR. So you just take across the height of the pedicle with some studies, and we did a cadaveric study. This is just for show to see the contralateral side. If you take 12 to 14 millimeters height and reduce that, it's adequate to release about 80–90% of the tension that subjectively we measure. And then basically once you're across and everything's free, you can kind of close it down. For show, we can close it down. So the screws above and below, you see. And once it's free, you get a rod in. You'll get a little dural buckling, so you have to be careful. There's a Chinese study in a pig model saying that you could actually decrease 1 full vertebral height before you get nerve changes. And the dural buckling, just be cognizant of that. You might have to release it a little bit if you overdo it. And you can always put a little mini cage or graft in the front if you need to. And then basically, once we feel like we've adequately decompressed all the bone, ventrally, the posterior wall is released as well, we'll just put a compressor in and shorten them. Generally works pretty well. So there's the compressor. Not that long. Right, there we go. And we'll just compress it down. And you'll see a little bit of the dural buckling as you do it. And again, most patients tolerate, certainly with this, but even up to one vertebral level. And this is our post-op. So you can see the AP lateral, kind of the wedge or bone that's left, and then the pedicle and the one that's removed below that. And she did great. Post-op, she had improvement. She had her strength came back a little bit, sensory improved, and overall has been doing well about a year and a half out so far, I think, maybe 2 years from her surgery. Between where I was before and now, we've probably done 12.5 adults and kids. I think it can work great for both, especially myelo patients. In revision, this tends to be away from the scar tissue, so you're not going back into area that's not healing well. It's had multiple surgeries. That's risk of leak and wound issues, and you don't have to worry about the sagittal alignment as well because it's a fairly straight thoracolumbar junction. And then there's a couple. Andrew J. published a meta-analysis a couple of years ago looking at 15 studies and almost 200 patients, and really much like tethered cord. They found pre-op pain improved the most, about 85% in their series. Motor was a little less at 60, gallbladder about 47. So kind of very similar to what we see with recurrent tethered cord, about 30-40% improvement after recurrent tethered cord. And then pain usually closer to 80-90%, and sensory and weakness in between there. And overall, they had a fairly low complication rate, 4.5%, which is fairly low given you're doing a 3-column osteotomy in the patient. And then there's another paper that looked at a retrospective series of 7 patients with similar findings. Basically, some of the earlier series, motor function had a good improvement, pain a little bit above that, sensory less, and gallbladder slightly least. But it's very mixed. It's a very mixed group. Just it's not, we don't have as many patients who've had this done yet. This is just an illustration of the same thing. Taking a lateral, you want to take the pedicle out, everything above the pedicle and the disc. Then you can just get bone-on-bone compression and kind of closure. So overall, it can be a challenging diagnosis. Tethered cord is quite mixed in terms of the radiographic finding, the clinical presentation, and the treatment options. But at some point, recurrent detethering may not yield the best results. And one option maybe is shortening osteotomy. I think personally, I like it. It's usually a clean area. A couple hours, you can compress it and close it down nicely. And to date, I haven't seen so far. I haven't had any bad luck with it yet. But overall, compared to like a recurrent detethering, it could be quite problematic and difficult. So overall, basically the natural history, balancing everything. Other cords are trying to look. Not that we understand the natural history well. We're trying to balance that when we decide on intervention. For me, things that are lower risk, like a fatty phylum, I'm more inclined to detether or re-detether versus more complex, like a lipo or terminal lipomyelomeningocele, things like that. The literature isn't great yet. We're still pulling data together, and hopefully more multi-center studies will happen and help us understand this better. Because all we don't know, the similar patterns we saw with Chiari and Intraspinal Anomalies seem to carry through tethered cord so far. So we want to, if you're going to intervene, you probably want to do it a little bit earlier and at a younger age. But it's a little more complicated with potentially tethered cords. With deformity, some of the neurologic issues may actually come from the deformity, not just the tethered cord. So this is an example of an 11-year-old girl. She was a foreign child. So she was treated in India originally and had a split cord malformation treated, and then had a CSF leak and treated there. And it was actually fine for years. So like 10 years of her life. And about a year and a half ago, started having weakness, progressive weakness of right leg. And so it was referred to us through our international program. So we tried to get her in. We were just not quickest yet. So it took us about a year, unfortunately, a year and a half to get her to us. We could see the kyphosis she has. There's some component of congenital fusion anteriorly, and the cord is a little compressed in the back. There's a CT showing same thing like kyphosis. With probably the prior surgery, there's a little bit of laminar defect, a little bit of kind of some bone spicules that extended down along the dura. By the time she got to us, which was a little bit longer, really she was not moving the right leg at all to voluntary, and the left side was getting a little bit weak. She was like 3 in the SOS, quads were about 4, but she was emptying her bladder, so she had maintained bladder control at that time. So we put it in traction for a little bit. The dilemma in her was, was the neurologic decline from ventral compression from the kyphosis, which could be very plausible, or could it be from a tethered cord, like distally? Is that causing or contributing, or is it both? So some of these cases can be difficult to flesh out, and maybe you just need to treat both. So we originally talked about putting in traction just to one, to see if we could pull things up above a little bit, and just to give me a little bit of time to work her up and ponder things. But she actually deteriorated with traction, got a little bit worse with traction. So we stopped, we eased up, and given she was fused in the front, we felt it wasn't that reasonable to put in traction. So we just did a 1-2 VCR with the cage at the front and fused it posteriorly. And then okay, just correct her alignment a little bit. And mostly the main goal is to decompress that ventral compression. So if it takes out the cord compression and shorten her a little bit in doing so. Often with these cases, I find getting a temp rod early, even if you feel it seems solid and there's a little movement, getting a temp rod and compressing early helps. It takes a little bit of tension off. Hopefully the cord can perfuse a little bit better. Which is also why we like traction for big curves. We'll often hang kids up in halo gravity traction for about 6 weeks with the idea that they can auto perfuse a little bit and hopefully increase their own auto perfusion. So she actually did well. She luckily improved and is walking now, thankfully for that. But back home in India, braced them for about 6 months after. So your question was, does the intraspinal anomaly or the deformity need surgery? What's the cause? And so this is my general algorithm, and it's probably in evolution still. But obviously, if there's no neurologic symptoms, no what we call it, clinically tethered cord, really just the deformity aspect, then I would just treat the deformity. Whether you need to treat it with a shortening osteotomy or not, probably depends on how stiff the curve is, how big it is. Just focus on primarily controlling the deformity. But obviously, they have neurologic symptoms a little bit different. They have tethered cord, symptomatic, then clearly we'll typically treat that. If they have compression from the deformity, the kyphosis will treat the deformity. So try to get 2 birds with 1 stone. Try to take the kyphosis off, like that last example, and correct some of the deformity at the same time. And then controversy, probably the debate is whether deformity is a sign of the tethered cord, and that we could still debate. I personally think it probably is, and there probably is a contribution from it, but how much does it have to be to decide if you can intervene is a separate, so threshold for intervention is probably variable for each surgeon. And then, so if you feel they are symptomatic from the neurologic cause, generally if it's simple, if it's an index surgery the first time, or they have minimal functions, or they're not likely to make them worse, I think it might be more favorable to go and release it or detether them and just do the detethering for a part of it. But if it's more complex anatomy, like the earlier kid we saw, they're high functioning, so you have more to lose, or it's been 2, 3, 4 times, then I'll lean towards the shortening osteotomy, maybe not quite deformity surgery, but taking like a VCSO and shortening them a little bit. And currently that's how I approach it and where I'm at with things. But as we're learning, every year we're learning a little bit more. There's new stuff coming out, and we'll probably evolve a little bit. Overall, again, radiographic tethered cord may not need to be addressed prior to deformity correction. Clinically is different. And vertebral column shortening osteotomy may be a viable option really to treat tethered cord syndrome. Again, especially with those parameters. And you can also use it to treat deformity if they're both present. You can treat the kyphosis, or if it's a lot of deformity in the concave pedicle, and take that out as you correct the deformity at the same time. Great. Thank you all. That's all I have for today. Let me stop sharing. Any questions from anybody?
Well, thank you so much. That was a very informative talk, and something that we don't get to see very often. So we really appreciate that. Just would love to open it up for questions to the group. I do have a couple questions myself, but I'll leave it to you guys first.
Thank you, Dr. Hwang. This was outstanding yet again. I want to thank you and your group also for recently having done a very memorable Tuesday evening interesting case conference. And this is just a continuity of the excellence of your work and that of your group. And very comprehensive, incredibly complex topic. For me, one of the biggest things is the power of prediction and how to translate that for just conventional. I'll start with adolescent idiopathic scoliosis. There's been such a number fixation through the ISSG. This is one of our groups, one of our partners, Dr. Hart was a leading member of that. And this is complete numbers fixation on that. And I see that in a similar fashion sometimes applied to kids. And in our practices, Dr. Abdul Jabbar, Oscar, and I frequently see adults who've had neglected scoliosis surgeries in their youth, and they come with these horrendous deformities that then are very difficult to pull apart. At the same token, we see patients coming to us for second opinion, sometimes from a pediatric hospital here, and they're these young kids, and they have a curve of about 60 degrees, and they have no pain. They are state volleyball champions. They are swimming champions. They have no neurologic issues whatsoever, and they're skeletally mature, and their parents want this fixed, and the kids have no burden. So how do we find wisdom in numbers, and when to intervene surgically in neurologically intact patients, and when to kind of say, hey, just let's wait it out for a couple of years until such time? So this wisdom in numbers, the help of numbers, and how to translate that clinical practice is very hard for me to see that, and I'd love to hear your perspective.
Well, sure. I think it's a great question. It's certainly something we all struggle with. I think the natural history studies that everybody tends to hang their hat on for AIS are not great studies. They're the best we have. So Weinstein studies looking at 30, 40, 50-year follow-up. Unfortunately, follow-up somewhere like 60%, people move, so you don't have the best follow-up. And it's not clear. Some patients, like you said, may come in at 80 years old and 80-degree curve and feel fine, asymptomatic, they do great. They don't need anything. But people get fixated on that number 50, unfortunately. I think there's enough clinical equipoise, even for like maybe 55, 45, 55, where we don't know. Somebody's skeletally mature, asymptomatic. I think personally it's very reasonable to watch them. I do let them know that the best of our knowledge, on average, the curve progresses a little less than 1 degree a year over 30, 40, 50 years. But whether they have surgery now or in a couple of years, if they're 14 or 17, 18, it probably doesn't make a big difference. I think it's probably a gradual spectrum. If you took somebody who's 45 versus 16, yeah, the complication profile, the curve will be stiffer, the recovery is a little slower, there's probably more blood loss and a longer fusion, but a couple of years probably won't make a big difference. And I think a lot of it is kind of a patient decision making. You really have to engage the patient, decide what's important for them. Like you said, if the child is totally fine, doing great, why put her through the risk of the surgery, the complication? Watch it a little bit, see how they do. And eventually, if it progresses, it might declare itself, then they'll feel more ready for it. Or if something bothers them, usually I ask them if there's any pain, which I routinely ask them. Pain isn't always correlated with scoliosis, but we do see it often in general in these patients. Are they worried about the appearance, the prognosis, their back, or they have any disability from the scoliosis? And if they're not, and they're totally unperturbed, I would just watch it, keep an eye on it, and just keep a discussion going with them. I hope as we understand more, so we're big efforts to understand kind of adolescent idiopathic scoliosis as these kids grow up into adulthood. Part of the problem is we just don't follow them. So a lot of pediatric centers see them till 20, 21, and then they kind of graduate and they disappear. So we don't see the problems that you guys see, or when they come in, how they're doing. So we have a very biased perception of, oh, they must be doing great, they graduated, they're going about their lives. But that may not be the case. And so hopefully with these new long-term studies, we'll get a better idea of how patients with fusions are doing really, and how, if they're unfused, and in 20s and 30s, how they're doing really. We'll be able to answer that in a much better fashion.
And then Steve, just on follow-up on Jens's comment about when to operate, how much, when you do these surgeries, how much of an emphasis do you put on derotation and what kind of, because what I've seen, again, Jens and I obviously don't do adolescents here, but Children's Hospital and our colleagues, both in the city and the country, in the old days, it would be like, okay, just do T4 to L2 to anybody that walks in, right? And as surgery's evolved, hardware's gotten better. You know, if you can get a lot of segmental correction and derotation in the thoracic spine, a lot of times you don't even have to go to the lumbar spine. Can you talk about like what kind of screws are you using, what kind of hardware, these robotics, navigation, and how much of an emphasis do you put on derotating the spine? Because that's a huge thing right now, I think.
Yeah, it is. I think it's important. I think my more important is probably just keeping the patient obviously safely done and balanced. But there's a big emphasis on derotating, so the three-dimensional aspect of scoliosis. And I think it's particularly important when you have, like you said, like a shorter construct. We used to use T4 and L4 all the time. They're just a no-brainer. But that was before we had pedicle screws, stronger tools to derotate and fix the sagittal plane. Now, we have a lot of motion analysis showing that it's important to keep the lumbar motion intact. So we'll try to stop shorter. And I think we managed to push the envelope forward with that, with more powerful. Peter Newton's published showing for idiopathic patients, if you coronally correct the thoracic curve more, if you derotate it more, and you level the LIV, you get more spontaneous improvement in that lumbar curve. So that's particularly important in those cases. And hopefully that also carries over long term. So hopefully you get less BJK, less instrumentation failure. So we'll do, and it's probably not necessary, but we do high implant density, pedicle screws everywhere. Navigation helps. We usually freehand to start, but I think navigation is incredibly useful for that, for some challenging screws as well. And I think it helps elevate everybody's overall outcomes. So it brings up the playing field. And then I think, I personally do Pontes routinely across the apex, but that's controversial. Some people don't like it because there's an increased potential risk doing the Pontes. I just think it increases the three-dimensional correction you get. So Samdani, my colleague, published that, showing you get a degree or two more each level you do it. 1 degree probably doesn't make a big difference at a single level, but it adds up potentially if you do 5, 6. And then the rod material has changed. Like you said, the technology has improved. So the screws have evolved a little bit, but the rod stiffness and rigidity has improved a lot. So I think the newer rods give us better correction. I'll actually pick particularly stiff rods for selective thoracics to really get a lot more kyphosis. But I think you can achieve that. Some expert technician, Peter Newton, or masters in surgery can really achieve a lot of kyphosis. I think I can get away with try and create more by just taking a stiffer rod and forcing the spine to do that a little bit. So cheat it a little bit. But I think that's important for those selective thoracic cases. And so we've kind of moved a little bit more towards that. I think it's something we want to study a little bit more. But high implant density is something we do a lot of. I think all that helps create that three-dimensional correction. So the derotation, the kyphosis, and leveling everything to make it more kind of a harmonious correction.
Great. So it sounds like you're using fixed angle and also multi-axial screws, and then are you using cobalt chrome or titanium?
So I primarily use cobalt chrome. It's kind of very mixed. People are doing. I use shifted primary to 6.0 cobalt chrome for the rods. Sometimes both rods. Well, you typically use uni rods for I'd say an easier or less big curve. The curve is very large. We'll use more polys just to make it easier to reduce. And then sometimes I'll actually use like the rail to get the I-beam I just feel it's really powerful. It can be a little too powerful at times, but it can really create that kyphosis for me. So for select cases, I'll use kind of the rail for that kyphosis. It's kind of a mix of the two.
Great.
Let me ask you another question about, let's start with the tethered cord syndrome. So I find the clinical diagnosis of this to be sometimes very, very challenging. There's obviously a radiographic component, but a lot of these patients have a plethora of complaints and symptoms, and they learn a little bit, they look a little bit into the Google University and acquire some symptom descriptions. It's very difficult to sort out what's really going on. Are urodiagnostics and are there any neurodiagnostics that provide some objectivity to what we're actually looking for in our assessment, aside from an objective neurologic exam?
It's tough. I think I've tried to use it a little bit, sometimes more to rule that out. If somebody comes in and I feel like I don't feel convinced they have tethered cord syndrome. I think urodynamics more often than not help rule that out. So if everything's totally normal, I'm less inclined to intervene. But it's not always something I would hang my hat on. I think if you see obviously signs of sphincter dysfunction or neurogenic bladder, things that can be useful. I think time is probably serial exams probably helps me the most. Somebody who's in that gray zone, I'll see them and at least get an assessment that I trust and I know like what I examine, and then follow them over time and try to get a better sense. If they deteriorate, certainly objectively, like they're getting weaker, the gait's getting worse, things like that, then I'm much more comfortable recommending surgery. But if they're not and they kind of sit in the same very subjective complaints, then I kind of will stretch it out and watch them longer, maybe buy more time by getting dynamics or EMG and some kind of the nerve conduction studies I haven't found as useful, except to rule out like peripheral neuropathy. So if they have other stuff going on that might help explain it, I think it'd be useful, but not necessarily. I haven't found it as useful for this like tethered cord per se.
Great point. No, thank you. This is something, again, that we probably struggle more with an adult population. It's either completely unrecognized or the patients acquire a lot of knowledge or illness conviction that then makes it difficult. And I think the serial exams, I completely concur, is very helpful over time. And sometimes it parts the clouds. The other thing that's been a frequent conundrum for us is the Chiari syndrome, especially in an adult population. I mean, the same symptom cloud and variants of things comes into play, and I want to include our cranial colleagues here, which is the beauty of being here at SNI with really knowledgeable neurosurgical colleagues around. Do cineflow studies revolutionize our understanding of the hydrodynamics of the craniocervical junction? These modern new MRI flow studies, which are just kind of beautiful, is that just more technical chitter chatter?
I'd love to hear what the cranial colleagues think. I will get it sometimes. I haven't found I'm able to hang my hat on it yet. So it's been I feel like there've been different iterations of it last decade or so. So it's kind of improved in terms of the quantitative number you get from it in the studies. But I still feel like it's one more piece of the puzzle I think I used to put together. But I'd love to hear if other people use it more heavily or less.
Is Dr. Litvak on? Or Rod, what are your thoughts on cineflow studies? For me, again, the hydraulics and understanding the
I mean, I think they're helpful. I just don't know for pediatrics, Steve. Definitely for adults, but for pediatrics, the parents get freaked out. If you do more than X number of MRIs, and so. Do you guys do a lot of cineflows for?
I get it once in a while. Not all.
Yeah.
We don't have a radiology center, so we have to. It gets a little more complicated. You order something and they do something different, and then it gets lost in translation. And kids sitting there for a long time can be tough on the kids too. We don't want to sedate them. We don't have to. So it adds certainly a layer of complexity that can be a little bit of a headache.
Looks like Syed, you may have had a comment. Please, in our last couple of minutes, go ahead. Going once, going twice. We are just about 1 minute left here. My question was similar along the lines of the tethered cord and how do we kind of differentiate those real things. So you addressed that very well. Anyone else with any last kind of burning questions in our last minute? Please feel free.
Thank you all.
Good job. It's awesome to see the neurosurgeons diving in and doing the deformity, especially pediatric stuff. So, and I know you work with orthopedic surgeons as well, but it's really a very fascinating field, especially since you have to deal with the parents. That's like 80% of it, right?
Usually, yeah, the parents can be good or bad sometimes, but we love it. It's great. The kids are great.
Yeah.
But thank you for having me. It's
Yeah.
a pleasure.
Yeah.
Nice.
Yeah.
Great.
Thanks, Dave.
Thank
It's
you
great
so
seeing
much.
you.
Thanks, everybody.
Bye-bye now.
Bye.